first met Anthony, all I knew about him was he was a philosopher. And he said he lived near London, and we have a philosopher in the family. I know what they're like. So I said to him, so where do you live? And he said, oh, it's near London. And I said, well, is that inside the M25 or out? And he, I don't know. In spite of that, he's a very, very clever chap. He joined SPUC in 2011. He's now the Director of Research at SPUC. He's a visiting scholar at the International Theological Institute of Trumau in Austria. He's a former research fellow at the Anscombe Bioethics Centre, and he is a published author. 2 of his books, there are still just a few copies left at the back, which we'd like to sell before you all go home. So without any more ado, I'm going to ask Anthony to speak to you now. Thank you.
Thank you. After an introduction like that, I'm very curious about what it is I'm about to say. So thank you all for coming this morning. I'm going to be talking about euthanasia, and particularly about a document concerning tube feeding, which has recently come out. We live in a society wedded to the idea that broadly, the more options we have, the better. Even if there are options we never exercise, the very existence of such options is, we tend to think, a good thing. And increasingly, our society is wedded to certain ideas of freedom, understood not as the unfolding of human nature in ways that express our flourishing, the older view where our potential is something firmly tied to human actuality and our orientation to fulfillment as the kind of beings we are. Rather, this freedom is more and more seen as something untethered by the limitations imposed on us by our bodily and spiritual reality. The trend to untethered freedom carries with it profound consequences for all of us, and in debates about euthanasia, the results are increasingly evident. With regard to options, a society which tends to see extra options as unreservedly good ignores the following kind of problem. Certain options being on the table end up subjecting us to all sorts of undesirable pressures. Once a certain option is on the table as a live option, we can no longer go back to the status quo. When I was asked by John Smeaton to address this conference, I could no longer rest happily in my status quo position of not being asked and getting on with daily life. I was put in the position of either accepting the invitation or rejecting it. And even if I were not an employee of SPUC with certain duties reasonably expected of me, I should still not have been put in a position of actively having to turn down an option offered to me and risk displeasing John. And you can substitute that with sort of tiresome dinner party invitations or something like that for your own examples. Rather less trivially, think about the position pregnant women are now in this country, where the mere existence of the legal option of abortion changes the woman's position as being simply a mother of an unborn child into one where she is perceived by others, and perhaps herself, as someone who is rejecting the option of having an abortion. Even if she doesn't view herself in this way, others will, and those perceptions may well change her own view over time. The very existence of the option has transformed her situation. With euthanasia and assisted suicide, the very option undermines the status quo, where our own existence is simply a given. It seems that I didn't have to justify my continued existence until the option to do away with myself was introduced as a social norm. Indeed, as one philosopher points it, and maybe people in your family say this, excuse me for living. Well, that used to be a joke. Now it isn't. Well, the word euthanasia is derived from the Greek euthanatos, which means easy death. This doesn't tell us very much. Wanting to give people an easy death, whatever that amounts to, is hardly unusual. What distinguishes advocates of euthanasia is that they claim it can be permissible to deliberately end a patient's life. They can claim that it's deliberately to end a patient's life in order that he or she avoid pain or burdens or perceived indignities of some kind, usually associated with an illness. The presumption is that the patient is better off dead, so that it is sometimes morally justified to kill that person. It may, of course, be only the patient who is making a judgment about the quality of his or her life. And radical doctors who believe in an absolute right to end one's own life may be prepared to assist, regardless of their own personal views on a particular patient's quality of life judgment. Such cases are still reasonably called euthanasia, where the doctor carries out the final act, and physician-assisted suicide, where the final act is performed by the patient. Physician-assisted suicide, and that's the kind of legislation that people are pushing for in this country, is distinguished from euthanasia in that the patient, him or herself, deliberately brings about his or her own death with lethal substances supplied by another who shares the intention of the patient that death be brought about. Active euthanasia occurs where there is a deliberate intervention, for example, a lethal injection, aimed at ending the life of the patient, whereas euthanasia by omission, sometimes called passive euthanasia, is the deliberate withdrawal or withholding of medical treatment or food and fluids with the specific aim of ending the patient's life. Note that only if that aim is present are we talking strictly about euthanasia, as opposed to what may perhaps be fatal neglect, but is not deliberate killing as such. The condemnation of euthanasia as incompatible with medical practice goes back to the foundation of medicine through the profession of the Hippocratic Oath. Hippocrates, of course, lived around 460 to 370 BC, where the oath taker declares, "I will not give a lethal drug to anyone if I am asked, nor will I advise such a plan, and similarly, I will not give a woman a pessary to cause an abortion." Having promised that he will act for the benefit of the sick, the oath taker goes on to make this promise against two archetypal types of transgression, both of which betray the very meaning of medicine as understood by the oath, which requires the oath taker to, quote, "benefit my patients according to my greatest ability and judgment, and do no harm or injustice to them." Giving a lethal dose contradicts the meaning of medicine understood as the promotion of health, and destroying the body, whether born or unborn, is contrary to the very nature of medicine. The oath which gives rise to the profession of medicine is in the original Greek called horkos, which is related to herkos, which means fence. As the classical scholar T.A. Kavanagh notes, putting certain things outside of the fence renders the enclosed space fit for the activity of which it has been reserved. The Hippocratic view of medicine sees the doctor as assisting nature to restore harmony within the patient through the exercise of certain moral and intellectual virtues. The view of man expressed in Hippocratic writings sees him as a being who needs to be treated holistically and not merely as an assemblage of physical parts. This reflects a wisdom about human beings as living, goal-directed beings who must be treated accordingly. The man, not the disease, is to be treated, with the stress on the whole integrated person. In modern times, there has been a loss of influence of the Hippocratic conception of medicine, which distinguishes genuine medical practice from the practices of those who merely give the customer what he or she wants without reference to the internal ethic which makes sense of the medical profession. The process can be seen with successive updatings of the oath, which are vaguer in their reference to respect for human life, and introduce references to patient autonomy and well-being that provide better cover for abortion and perhaps eventually euthanasia. Hippocrates aimed to eradicate the deliberate wounding from the healer's role by means of the oath. Following Hippocrates' lead, the physician solemnly commits himself exclusively to promoting the health of the sick and specifies the wounds he will not inflict upon them, in particular killing, sexual exploitation, and violating confidences. Commenting on that oath, the famous anthropologist Margaret Mead once rightly observed, quote, "Society is always attempting to make the physician into a killer. to kill the defective child at birth, to leave the sleeping pills beside the bed of the cancer patient. It is the duty of society to protect the physician from such requests. Mead draws our attention to pressures on physicians, which are increasingly adding to pressures on patients and their relatives in our own post-Hippocratic and now increasingly post-Christian culture. Currently, the World Health Organization defines health as follows: a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Such a definition appears to have little to do with medicine as traditionally understood, for it covers not only basic bodily and mental functioning ordered towards human flourishing, but the whole range of goods in which a human being may participate, which may have little or nothing to do with healthcare. Is someone less healthy for not liking their job, or being less handsome and charming than they would like, or not as good at chess as they thought they were? When it comes to healthcare, the defining rationale must be the combating of ill health. It is a need which societies reasonably seek to meet with regard to their citizens. Medicine on the Hippocratic model is not about improving the lives of the relatively healthy in any way possible, but specifically about applying knowledge and skill for the benefit of the sick, and by extension, to prevent sickness in the first place. Without such a rationale, it is hard to see how the medical profession can have the internal coherence doctors need to develop the appropriate professional dispositions. Such was broadly understood by the medical bodies which formed the World Medical Association in 1947, and the Declaration of Geneva, which it adopted in 1948. I think John Deegan made reference to that yesterday, in the wake of the horrors wrought by totalitarian and other regimes. And that declaration commits the doctor in the following terms: I will maintain the utmost respect for human life from the time of conception, even under threat. I will not use my medical knowledge contrary to the laws of humanity. Moreover, the declaration says that the health of my patient will be my first consideration. Subsequent updatings of the declaration have tellingly dropped reference to from the time of conception, and now reference is made to health and well-being of the patient, perhaps to make procedures such as elective abortion appear more acceptable. In the UK, we know that our medical institutions, more than ever now, the BMA, the Royal College of Obstetricians and Gynecologists, etc., have been at the forefront of pushing for abortion to be decriminalised and more freely available. And now we have the Royal College of Physicians, through completely dishonest means, adopting a neutral stance on the subject of assisted suicide. As the assisted suicide advocate Professor Raymond Tallis, a prominent and elected member of council at the Royal College of Physicians, an important establishment figure, put it, I believe that we shall bring these bodies round to an appropriate stance of neutrality, and that with this obstacle out of the way, Parliament may indeed come to support legislation in favour of assisted dying. The majesty of medicine, as developed through the Hippocratic tradition, is utilised to push for an agenda which effectively says that medicine is not now something guided by meaningful internal ethic. Instead, customers should be given what they want in certain contexts, even if this seriously harms life and health. One problem with this is that it is hard to see why medical bodies should be given such a role in helping to decide these matters, when they themselves have emptied medicine of its role and turned towards an approach which makes medics mere functionaries, people who merely carry out the instructions of others without any mediating medical ethic with which to judge those instructions. In practice, we are returning to a pre-Hippocratic era, where the internal goal of the profession and the virtues required of its practitioners are increasingly set aside in favour of non-medical considerations and the promotion of practices which merely masquerade as healthcare while violating its goals. Well, these thoughts became acute to me when looking at a document produced last year by the BMA and the Royal College of Physicians, and it's called Guidance for Decision Making in England and Wales on Clinically Assisted Nutrition and Hydration and Adults Who Lack the Capacity to Consent. I'm going to use the phrase tube feeding for that because it's a bit of a mouthful. So, this document repays careful study for what it tells us about the nature of our medical institutions. It concerns tube feeding, which some doctors and nurses would regard as basic care, like hygienic care or wound care, which should not be withdrawn if it is still benefiting the patient and not causing undue burdens. Unfortunately, however, tube feeding is now routinely classified as medical treatment, and the result has been an increasing trend toward the denial of food and fluids to vulnerable patients. In the UK, the critical judgment came with Airedale NHS Trust versus Bland. Many of you will be familiar with this case, where construing tube feeding as medical treatment allowed the removal of food and fluids from Tony Bland, a man diagnosed as being in a persistent vegetative state who died soon after from dehydration. I'm going to use the term PVS, which is in the documents, but obviously the term vegetative itself encourages a view about people in these states. As Keith Andrew, leading authority on PVS and then Director of Medical Services at the Royal Hospital for Neurodisability, said in 1995, it is ironic that the only reason that tube feeding has been identified as treatment has been so it can be withdrawn. I would argue that tube feeding is extremely effective since it achieves all the things we intend to. What is really being argued is whether the patient's life is futile, hence the need to find some way of ending life. In the words of the legal scholar John Keogh, the law lords at the time decided that Tony Bland's doctor was under no duty to continue treatment and tube feeding if he felt that continuation was no longer in the patient's best interests, and if his opinion was supported, as it was, by a responsible body of medical opinion. Indeed, if the doctor held this belief, he was actually under a duty to withdraw. But why should the judgment about which patients have lives worth living be delegated to a responsible body of medical opinion? Hippocratic medicine certainly does rule out withdrawals for the specific reason that the patient's life is now judged to have no value at all. However, Bland effectively told us that tube feeding is medical treatment which can be withdrawn if it is no longer in the patient's best interests to receive, because it is no longer in the patient's best interests to live. Subsequently, the Mental Capacity Act of 2005 created the statutory legal framework for making decisions on behalf of individuals who lack mental capacity in their best interests. The Mental Capacity Act classifies best interests in highly subjective terms, downplaying clinical best interests. Thus, decision makers must take into account 4.6. A, the person's past and present wishes and feelings, and in particular any relevant written statement made by him when he had capacity. B, the beliefs and values that would be likely to influence his decision if he had capacity. And C, the other factors he would likely consider if he were able to do so. It goes on to list others who should be consulted. As John Keogh put it, one way of denying the worth of incompetent patients is to adopt the judgment that the value of life depends wholly on the value people give to their life through their choices, and that the loss of one's capacity to choose means that the only value in one's continued existence depends on the value one has chosen to attach to one's life when competent. Such an approach is inconsistent with the ineliminable dignity which we all share, whether or not we are competent. The highly selective criteria of the Mental Capacity Act for assessing a patient's best interests were slightly offset in the eyes of some by the clause in the Act which stated, 4.5, that in relation to the determination of the best interests of a mentally incapacitated adult, where the determination relates to life-sustaining treatment, the person making the determination, quote, must not be motivated by a desire to bring about death. While this statement sounded good, it has subsequently been gutted by court cases. And by the time we get to the document I'm talking about, readers find in the document the following, quote, and this came out last year. Decision makers must not be motivated by a desire to bring about the death of a patient. In describing the patient's likely reaction to their current situation, however is a bit like but, you just delete what came before it. Those close to the patient frequently use expressions such as, he would rather be dead. This does not equate to a desire to bring about the patient's death and should not be interpreted as such. While doctors garnering information are instructed in the document not to be guided by their own views on quality of life for patients in the relevant condition, either positive or negative, but simply to focus on what the patient wanted or would have wanted, plus any current good or bad experiences of the patient. It says, quote, decision makers must start from the strong presumption that it will be in the patient's best interest to prolong life, but for some patients, providing or continuing to provide tube feeding is not in their best interest because it is not able to provide a quality of life they would have found acceptable. Well, in 2017, the Director of Legal Aid Caseworth versus Briggs, the Court of Appeal suggested that Practice Direction 9E, that's from the Mental Capacity Act, does not create a legal obligation for decisions about tube feeding to go to court. So in PVS cases, you would still have to go to a court of protection, and it would be, so it was a big deal, it was a big protection, even though the law was misshapen as a result of Bland. But this case suggested that the practice does not create a legal obligation for decisions about tube feeding to go to court. Following a number of consequent cases supporting withdrawal of food and fluids, NHS Trust versus Y granted a declaration that there is no legal requirement for decisions about tube feeding to be approved by a court. And in the same case, the Supreme Court confirmed that there is no requirement for decisions about tube feeding to go to court, reaffirmed. Where there is agreement as to what is in the best interests of the patient, and the law and professional guidance have been correctly followed. So the court is completely removed from that where there's this agreement. It is in this legal context that the guidance I referred to appears. For any doctors in the audience, it is worth just mentioning that the guidance is BMA and RCP guidance, not GMC guidelines as such. Although the GMC generally endorses the guidance on the cover page and were involved in its creation, they explicitly say that this is not about threshold fitness to practice and that the guidance is a tool, not a rule book. So in working out the right thing to do, we should bear in mind a doctor's priority anyway, and doctors need to be aware of that. Well, it's very important to realize that the category of patients that the BMA and RCP guidance refers to are not just the narrow category of PVS patients and now patients in minimally conscious states, that is those with minimal conscience, but also other adult patients who lack capacity but are certainly not close to death and whom the guidance again admits benefit clinically from tube feeding. These include patients with neurodegenerative conditions, this includes dementia, and patients with multiple comorbidities or frailty likely to shorten life expectancy who have suffered a brain injury. This group includes those who suffered from catastrophic stroke. Let me reiterate, these are patients who are not imminently dying and for whom the authors admit that tube feeding is clinically beneficial. Moreover, the guidance refers above all to those who have not made any formal advance refusal of tube feeding, although some may have made an informal comment in the past about not wanting tube feeding or simply not wanting to live in certain conditions. So careful what you say. If you think, another 10 minutes of this talk and I won't want to live, say that to someone nearby. It could get you in trouble. So, okay. Others may be thought not to have wanted to live in a certain condition for some other reason, though doctors are admonished to look at the quality of the evidence. Formal advance refusals are often ill-informed, as the patient need not have talked in detail to a doctor before making them. How much more will this apply to informal comments to family and friends, which may not focus so much on procedures like tube feeding, but merely express a certain repugnance at living at all in a certain condition? So you watch a film and say, oh, I wouldn't want to live like that. That's an informal comment. You're talking about a future condition. That can be reported. In order to get this information, doctors are told to be very proactive in asking a number of people who know the patient their views on whether they would have wanted their lives sustained. It is extremely important for all of us to realize that if we are ever asked by a doctor what a patient's wishes might have been, we understand the risk that what we say about a patient having a negative view of life in a certain condition may well result in tube feeding being withdrawn and the patient dying if they're in one of these conditions, if not contradicted by other reports, such as reports about the patient enjoying their life. This is despite the fact that patients who incur severe disabilities typically rate the quality of their lives much higher than those without such disabilities rate such lives, including doctors and perhaps their earlier selves. Research has shown that there is a huge gulf between how patients in these conditions actually feel and what healthy people with understandable fears of these conditions think they must feel. As one philosopher put it, citing a number of relevant studies of patients with very severe conditions, quote, "Our assessment of what it is like to be disabled is radically incongruent with that of those who experience the disability firsthand. Consequently, we should be skeptical of our quality of life judgments from the third-person standpoint. We think locked-in state would be a bad way to live. People in locked-in state that we know about do not think so. We think minimally conscious state would be a bad way to live. It may be the case that they do not think so, to the extent that they can understand, that we can understand. Aside from this, of course, it needs to be noted that the rate for misdiagnosis of so-called vegetative state and a minimally conscious state is approximately 40%, 40. And as new diagnostic tools become available, the rate may prove even higher, with greater numbers having covert consciousness than presently thought. Moreover, when it comes to recovery from a prolonged order of consciousness, PDOC, that's the sort of umbrella term, the few studies that exist point to rates of improvement in awareness of up to 32%, and if limited to PDOCs resulting from traumatic injury, the rate can be as high as 52%. If we don't limit the outcome to an improvement in awareness, more recent research suggests that 20% of PDOC patients eventually regain independence in the home environment. Such stunning figures bear out what Baker J. found at the Court of Protection back in 2011. This is an example of the Court of Protection actually working, when he ruled that there was no reason for extending the approach of Bland to patients in PVS to those in minimally conscious state, a much wider category, and also refused an application to withdraw tube feeding from patient M, as it was not in her best interests for her tube feeding to be withdrawn. He went on to point out that a very significant proportion of patients who were diagnosed with PVS prior to the development of assessment tools, this is the judge, were subsequently found to have been misdiagnosed. As John Keown has asked, how many patients have been misdiagnosed as being in PVS, have had their tube feeding removed, and have been aware as they suffered a slow death from dehydration? And yet now, that's the good age. Now we have a situation where such cases can routinely bypass a court examination, and on the basis of the merest say-so of a relative or friend, a decision can be made to dehydrate to death someone said to be in a minimally conscious state, or even with more consciousness than that. Note that if the relatives say that the person did not want or would not have wanted, them burdened by their continuing to live, so if they ever said, I don't want to be a burden to you, okay, this too is being counted as part of the patient's best interests and must be taken into account. The document cites a court case, including as evidence with regard to one patient of the fact that he would not have wanted to live, the fact that he enjoyed riding a motorbike and was committed to his family. To quote, and this is from the document, "In making his decision, Mr. Justice Charles took a holistic approach to understanding Mr. Briggs's views about his current situation. He considered not just what Mr. Briggs had said about his wishes in relation to similar circumstances, for example, his support for his mother-in-law's refusal of a feeding tube at an advanced stage of cancer, so a completely different case, in fact, than what he experienced, as a different disease and a presumably terminal stage of that disease, but also how he lived his life and embodied his values through the choices he made in life, for example, his career in the army and police force, his hobby of riding motorcycles, and his love for and commitment to his family. This led him to conclude that it was not in Mr. Briggs's best interests to continue to receive tube feeding." Just as the law has withdrawn from protecting vulnerable people in these situations, so medicine is perverted, with even truthful communication being eroded. The earlier 2013 Royal College of Physicians guidelines recommended that doctors draw up death certificates in cases where patients are deliberately dehydrated to death, where the cause of death is said to be the original brain injury. As two scholars, writing in a medical journal in 2014, scathingly put it, this could be interpreted, it's very English, this could be interpreted as an infringement of the long-held assumption in society and law that medical profession holds truthfulness as one of its moral priorities. The new guidance, though a little less explicit, recommends those recording the cause of death exclude any mention of withdrawal of tube feeding, and that instead multi-organ failure or bronchopneumonia be listed as the direct cause of death, and original brain injury as the underlying cause. I remember seeing Professor John Finnis, who some of you may know, many, many years ago on television with a Dutch euthanasia doctor, and he asked the doctor, this was even before it was legal in the Netherlands, actually, and he said, "What do you put on the death certificate?" And the doctor said, "Well, I put death by natural causes." To which Finnis memorably said, "I see, so you lie as well as kill." Well, not only is this officially encouraging straight-out lying, but as my colleague Dr. Greg Pike points out, this means that research about tube feeding, removal of people in PDOCs, will become very difficult, if not impossible. You simply won't have the data in order to do the studies, to give these kinds of talks. Well, I've been talking about cases of non-voluntary euthanasia, presuming that in at least some of these cases, the withdrawal of tube feeding there is with an intention to end life. It seems to be being promoted. Euthanasia in these cases is being defended in terms of a benefit to the patient, which benefit is thought to include the patient's death as the kind of thing he either wanted in the past or might possibly have wanted or would have wanted in the opinion of a family member, a friend, a covert enemy or financial beneficiary or whoever. Note that here we have a stress on supposed best interests, seen very much in terms of supposed attitudes of the patient, reduced from the level of formal choices to the level of reported wishes or feelings the patient may have had in the past. Doctors are also told to factor in any current experiences of the patient, good or bad. Well, traditionally, euthanasia and assisted suicide have been said to be justified on two grounds, although these grounds are often combined. One ground is the best interests ground, best interests normally being understood in terms of the patient's current welfare, without, however, including this welfare, without including in this welfare any idea that life is intrinsically good. The other ground is simply that the patient autonomously decides that he no longer wants to live, such that he then has a right to demand that a doctor kill him or assist him in suicide. And here I'm speaking, of course, of voluntary euthanasia and a definite choice on the person's part. Well, euthanasia and assisted suicide in practice rarely involve an appeal to autonomy alone. If a doctor or indeed a lawmaker must judge that a particular kind of request is to be acted upon, because the termination of life would indeed benefit a certain kind of patient, then it seems that the mere autonomous requesting of euthanasia or assisted suicide is not enough. What is doing the justificatory work is the patient's perceived welfare or benefit, and not the fact that he has made an autonomous choice. But if that is the case, what justifies voluntary euthanasia also potentially justifies non-voluntary euthanasia, as people who can no longer request euthanasia may be thought to need it just as much. Of course, some philosophers are happy to justify non-voluntary and even involuntary euthanasia of those who want to live. Peter Singer and Jeff McMahon, University of Oxford, recently confirmed this to me. And they accept that there can be cases of involuntary where the patient actively resists. That's rarely stated, and you don't hear that very much, but it exists in our finest universities. As regards euthanasia by omission, very many people do accept, as we have seen, that those with prolonged disorders of consciousness can be deliberately dehydrated to death without their explicit consent. Many who accept non-voluntary euthanasia also accept voluntary euthanasia, and vice versa. Indeed, it would be odd for someone to allow for euthanasia, albeit by omission, of those who might have wanted it in the past, while refusing euthanasia to those still competent who formally request it. In leaving scope for non-voluntary passive euthanasia, the BMA RCP document is effectively preparing the way for full-scale acceptance of euthanasia, whether voluntary or non-voluntary, and whether by act or omission. Just as voluntary euthanasia can lead to non-voluntary euthanasia via a logical slippery slope, so too can non-voluntary euthanasia, as now seemingly endorsed, lead to voluntary euthanasia, and this appears to be the order of direction in this country. If euthanasia is good as ending suffering for those who can currently request it, it is also good for those who can't. Similarly, if euthanasia is good for those who cannot currently request it, how much more should it be allowed for those who can? Of course, nobody is saying that competent patients cannot be within their right to forego medical treatments. There are many situations where treatments can be foregone as too burdensome or insufficiently beneficial. And the patient should be allowed even some unreasonable refusals, as the patient has first responsibility for his or her health. However, the focus now is on foregoing basic care rather than medical treatment, and more importantly, on foregoing life itself, achieving self-termination. And such foregoing can be formal or deliberate on the patient's part, or increasingly informal, or merely presumed to be the kind of thing that they would have wanted. Family observations like, "She wouldn't have wanted to live," and "she wouldn't have wanted to burden us," are now affecting who lives and who dies. So what about autonomy as a justification for euthanasia, where the patient has indeed made the choice? The reason we are told that we need to take autonomy seriously, is because one way or another it relates to something called human dignity. Both sides, you like to use the word dignity. In order to respect someone's dignity, we are required to respect their autonomous choices, which reflect their nature as rational human beings. However, respect for the rational nature of the person is in no way the same as respect for each and every preference of the person. In the words of the philosopher J.L.A. Garcia, the main reason that a human person's preferences and will matter morally is that limited deference is a principal way of honoring her personhood, its preciousness, sanctity, and dignity. That means her preferences matter only because and insofar as they reflect her personhood. Especially, they are informed by her reason. As her mere likes and wishes do not seriously count, neither should an agent hide behind the rhetoric of autonomy to justify treating someone in ways that run counter to her dignity and preciousness as a human being. That would be to get things upside down. In other words, even the limited respect we should indeed have for people's autonomous choices, for example, their refusal to accept treatment that is burdensome, is based on their actual existing human dignity, a dignity which honouring other choices may radically fail to respect. The mere request from a person to amputate a healthy limb would not normally be accorded respect in the sense of acted upon by the doctor. We all make bad and immoral choices from time to time, or more often than that. But it does not follow that these should all be carried out by others because every exercise of autonomy is seen as sacrosanct. Indeed, if we were to adopt the radical position that any patient who asks for any procedure, if we were to adopt the radical position that any patient who asks for any procedure, I've lost my thread, should be given it, we immediately face serious problems. For a start, it becomes difficult to see what the practice of medicine becomes, as there would appear to be no structure to the practice or internal ethic apart from a simple duty to accede to whatever a patient or consumer happens to freely request. Indeed, any position other than the radical one with regard to autonomy does end up discriminating between choices and situations, and in such a way as to make other criteria do the justificatory work for ending certain lives, but not others. Or to put it another way, refusing certain requests for euthanasia or assisted suicide, but not others. The philosopher Felicia Nemu Ackerman argues that there are really only two defensible alternatives, including a radically permissive stance if we take the autonomy justification seriously. Quote, I see two reasonable policies. One is to let all competent adults decide for themselves what conditions, if any, render their lives too degraded to be worth living. This would mean legalizing suicide assistance for all competent adults and not letting the determination of competence hinge on whether outsiders approve of the suicidal person's values about dignity. The other policy would be to make physician-assisted suicide illegal for everyone. A society that pathologizes suicidal feelings of indignity and degradation in rape victims while endorsing them in the terminally ill is, I contend, engaging in a horrifying, odious form of bigotry. This seems to be a genuine problem for supporters of assisted suicide and euthanasia, who will ordinarily want to draw a sharp separation between those autonomous requests which must be respected and those which must not be. It would appear that some kind of welfare consideration will have to come into play. This is not just a matter of autonomous requests. And as we've seen in Belgium and the Netherlands, once welfare is involved in doing justificatory work for killing, the position of the non-competent patient, who is not currently asking to be killed, is radically undermined. Indeed, just the other day, we read a Dutch doctor who sedated a woman with dementia and had her family hold her down so she could be euthanized by lethal injection has been acquitted of murder. The court in The Hague found that the unnamed doctor had acted with due care and fulfilled the criteria of the Netherlands' euthanasia law. Well, how did we get here? One of the deepest problems in our society is a false notion of freedom, often coupled with what some have termed an ethics of humanitarianism. Both these notions get things the wrong way round. It is only because persons are important that their objective interests, and sometimes their wishes and choices, must be respected. But very much part of people's importance is the intrinsic value of their lives. If someone says their life has no intrinsic value, why do we have to accord their wishes supreme importance? If they answer, because I am morally important, then isn't part of their moral importance the importance of their being there at all? Their wishes have importance only because they themselves possess an importance and value, not the other way round. Moreover, the value of life is not just their own. As David Velleman points out, if a person had the right to end his life on the grounds that it wasn't worth living, then he would have the right to be guided by his own judgment on that score. One reason for rejecting this principle is that a life confers benefits and harms on people other than the person living it. Does a person have the right to deprive his children of a parent simply because life isn't worth enough for him? Views of liberty which detach liberty from the value of human beings are ultimately incoherent and destroy real liberty, that is, freedom for flourishing as the kind of beings we are. For instead of attending to reality and understanding our potential in terms of what we are, we end up determining value and reality in terms of people's wishes or feelings, removing human nature and our physical welfare from its proper place in moral evaluation. As well as a false notion of liberty, we have to contend with a morality that bases all moral decision-making around man's relatively immediate needs, without any reference to higher purposes. There is the idea that there is really nothing sacred other than one's own present needs, or perceived needs, and those of others, and a failure to consider how legalizing euthanasia and assisted suicide will affect future generations, and how the normalization of such practices will affect humanity as a whole, creating one more way of dying as though it is like all the others. In this universe, human suffering is seen as a greater evil than, say, killing the innocent. Indeed, killing the innocent may be seen as not an evil at all, if only it ends human suffering, something all-important. Lost is all sense of a limit on human sovereignty, and of the fact that there are intrinsic evils which can never be outweighed by suffering and are never a solution to that suffering. Such a world, ultimately, is a world without love. Real, unsentimental love seeks the true good of the loved one, and above all, appreciates the loved one, which includes appreciating the loved one's very existence. Love might even be summed up as saying, "It is good that you exist." Existence is not only good for the person, even in an extremely fraught situation, but appreciation of that existence is very much part of a complete love for him or her. Hippocratic medicine acted as a protection of this love even hundreds of years before Christ. In contrast, a patronizing, sentimental humanitarianism is an approach based on feelings detached from their proper place in realistic love. It seeks to benefit human beings without appreciating the ultimate value of their existence, and I would add the ultimate cause of that existence. It places wishes and feelings above reality, even when these radically conflict. In doing so, it robs humans of their dignity, the respectful love that is due to them, and makes suicide an apt expression of where our modern notion of liberty is ultimately leading. Thank you.